In previous videos, we learned 1. That ventilators can have different modes of air delivery. 2. That different patient conditions need different air delivery modes. 3. Today we will learn why and how anesthesiologists use above knowledge. Stethoscope. Why do anesthesiologists use different ventilator modes? As an anesthesiologist, your goal is to maintain adequate ventilation and oxygenation during surgery or critical care, while protecting the lungs and adapting to the patient's condition. Counterclockwise arrows. Button 1. To match the patient's consciousness and muscle activity under general anesthesia, the patient is often paralyzed and cannot breathe on their own, requires full control mode, e.g., volume control. During emergence from anesthesia, spontaneous effort may return, switch to supportive or synchronized modes, e.g., SMV, PSV.
2.
To prevent ventilator-induced lung injury, VILI, different lung pathologies, e.g., ARDS, COPD, need tailored ventilation. ARDS use lung protective strategies, low tidal volume, higher PEEP. COPD/asthma, longer expiratory time, avoid air trapping. Test tube. 3. To manage gas exchange, precisely use modes like pressure-controlled ventilation, PCV. 2. Improve oxygenation, reduce peak pressures in patients with low lung compliance, use volume-controlled ventilation, VCV. 2. Ensure fixed tidal volume, track minute ventilation more accurately. Wrench. 4. To facilitate weaning postoperatively or in ICU as patients regain strength, anesthesiologists or intensivists use partial support modes like SMV, synchronized intermittent mandatory ventilation, PSV, pressure support ventilation, CPAP or BiPAP for minimal support. These modes encourage spontaneous breathing and reduce dependence on the ventilator. Clipboard summary. Table mode. Use case. Why it matters. VCV, full control under anesthesia, guarantees fixed volume. PCV, ARDS or lung injury, limits pressure to protect lungs. SMV, weaning or light anesthesia, allows spontaneous plus mandatory breaths. PSV, spontaneous breathing support, reduces work of breathing. CPAP/BiPAP, non-invasive support, keeps airways open, e.g. post-op recovery. Brain key principle for anesthesiologists. Ventilator mode selection is dynamic. It depends on patient factors, surgical factors, and timing, pre-dash, intra-dash, or post-op.